of any lung problem and any oxygenation issue. Respiratory failure is our worsening condition. And so really, it just adds on to the other. It's basically the slides that go on the end of every worsening condition. And the big thing I want you to know is the definition of respiratory failure. First of all, it's one or more of the following if you're on 60% or more of supplemental oxygen. So again, knowing when you've hit that mark by knowing when are you at 60%, what level face mask, what level nasal cannula, when are you at that mark? Like, okay, I'm above 60% of oxygen and I am still having problems. That is respiratory failure. Okay, when you are at 60% or more, so that means that you are on 100% oxygen and you're having any of these problems, you're in respiratory failure. Okay, it doesn't mean you are going to die. It just means there is an immediate intervention needed. Something more is needed. You're in your airway and breathing piece of your ABs. Did you lose internet? I don't think so. No. Can you all still hear me? Apparently we're having internet issues. Anyone? Okay. No, we're good. So I guess I'm not having internet issues. I'm on a different, good. I'm glad I'm on a different wavelength than the rest of my house. Good. I'm glad you're here. Let me know if you can't hear me, if I disappear. So if you are having on 60% more of supplemental oxygen, any one of these signs or symptoms, you are considered respiratory failure. So any signs of inadequate oxygenation or increased work of breathing, which I have a whole slide in the next slide on hypoxia, anything that counts as hypoxia. The other two you can only get off an ABG really is hypoxemia, meaning low blood oxygen level, meaning a physical reading from your blood vessels of a PO2 less than 60. Or you have hypercapnia, meaning you have high CO2 levels. Both mean that exchange is not happening across the membrane. So hypoxemia means low, it's different than hypoxia. Hypoxia is signs and symptoms of inadequate oxygenation. Hypoxemia is physically having no circulating oxygen. And that will be shown in a lab result. Hypercapnia is a presence of too much CO2. And that's what gives you a low pH. So if you have an ABG, you already got two of your criteria right there. But let's look at our unmeasurable criteria or our non-lab criteria. These are going to be the first things we're looking at. And these are all basically signs of increased work of breathing. Well, we said tachycardia and restlessness, confusion, anxiety. This patient cannot sit still. They are confused, anxious. This is not getting oxygen to the brain. The brain starts getting really panicky when it's not getting oxygen. Any cyanosis, gray or blue tinged mucosal membranes. Rapid, shallow breathing. So not just tachypnea, but tripoding. People who cannot breathe will sit forward. Tripoding is meaning you are sitting forward with your hands on your knees or leaning forward. So patients, and this is why we were saying patients don't like to prone, because one of your hypoxic instincts is to sit forward. You're actually somewhat proning yourself by lowering your chest, getting those organs out of the way and trying to expand the backs of your lungs, getting air to those backs of those lungs. Orthopnea means you have to sit upright to breathe. Any difficulty speaking. So of course, if you've ever worked out and gotten short of breath, doing that at rest, difficulty speaking at rest. Pursed lip breathing is where you are actually, if you do that right now, you're all off speaker. If you purse lip breathe, you can actually feel the increased pressure in your lungs. So if you breathe out, you're creating resistance with your mouth. When you purse lip, you're creating resistance to air leaving. and that is actually helping increase the pressure in your lung space. We are actually trying to increase our own PEEP, which we talk about in a little bit. Pursed lip breathing, and then of course after you've tried all this, breathing takes a lot of muscles, and your diaphragm wears out. You start using your accessory muscles, or you have extra muscles to help you breathe, and here are all your accessory muscles. So if you start, and one of the places I see it on exhausted patients is in the neck. You start seeing neck muscle movement with each breath because you're trying to pull extra muscles in to help the diaphragm. The diaphragm's getting worn out or can't do what it needs to do. So you're using these extra muscles, your abdominal muscles, your pecs, your neck. You don't need to know the names of them, but just when you have extra muscles being used to maintain your breathing, that's not a good sign. If you start seeing accessory muscle use you're on high oxygen levels, that's a good sign of respiratory failure. So what do? You're in a worsening condition. This is where you need to do something. You cannot leave the patient. Any patient, and let me guess, probably your test questions, they're all going to be in respiratory distress or respiratory failure. And that's once you've gotten up to 60% or higher of oxygen, and you are having any hypoxic signs or symptoms, or you have an ABG that confirms respiratory failure, you're going to go to these steps here. The first thing you're going to do is go ahead and put on a continuous pulse ox monitor. If you haven't already, go ahead and do that, and you will be doing very frequent respiratory rate, respiratory effort assessments. Clear or suction your airway if you can. If your patient is having trouble breathing and they are using all of their energy to just inhale and exhale air, this is probably not the time to do, hey, let's cop deep breathe. Let's do the incentive spirometer. They can't even maintain their actual tidal volume, okay? They're not going to be able to take nice, big, deep breaths. They're not going to be able to relax and calm down. They're in a panicky state. But if you can help maybe bang on their chest, they may actually let you suction them, get those mucus out of the way. You can suction them down their nose or down the back of their throat to try and clear the airway. Again, probably not the best time for the incentive spirometer when your patient's in respiratory failure because they don't have enough energy to even breathe in and out. So they're not going to have enough energy to take a nice deep breath on their incentive spirometer. You can try it, but it's probably not going to work real well. Turn their oxygen all the way up to 100%. Okay, just go ahead. You're already greater than 60. Just go all the way to the 100% non-rebreather and call for help. You are no longer able to do it all. You are now allowed to give up help. Your patient is in respiratory failure. You can see these signs of hypoxia, and you're already at 60 to 100% oxygen. Call out for help now. This is where you need help. This is where you get your charge nurse, your doc, your respiratory therapist. You have rapid response teams. This is the time to do it. They'll get ABGs, verify your hypoxemia and your hypercapnia. You can get chest x-rays, diagnostic exams, figure out what exactly is going on with your chest. But basically, a patient in respiratory failure, if you can't get them cleared or improving on 100% oxygen, then they will go two ways. If they are unconscious or breathing less than 12 breaths per minute, we will assist their respirations and probably ventilate them. If they are conscious still, we will go to non-invasive ventilation, which is CPAP or BiPAP. So the next interventions there are CPAP, BiPAP for conscious patients. You have to be conscious and spontaneously breathing in order to use CPAP or BiPAP. If your patient is unconscious, they can't protect their airway, and we are pushing air in and out via a mask with non-invasive ventilation, they have to be conscious. If they are unconscious, then we are going to go the other route and support their respirations and probably intubate them. But if they are conscious and still breathing, just not doing well, we will try CPAP or BiPAP, and we're going to add some pressure to the system to help the lungs get air. So just a review. These are where you're going. If your patient's in respiratory failure, you should be one of these two things. You shouldn't be on a nasal cannula anymore unless it's a high flow nasal cannula. Okay, you should not be on your nasal cannula anymore. You should be on a rebreather mask. What makes it a rebreather is not the bag. The bag is just an oxygen reservoir. What makes it a rebreather are these little discs. Okay, this disc versus not having a disc. Okay, or having a disc with air in it. When you have the disc on, it basically, when you suck in air, you pull the disc across and all you're breathing in is 100% oxygen from the wall. And then when you exhale, the disc lets up and lets CO2 out. Okay. The bag is just an oxygen reservoir so that you have more oxygen kind of stored. So if you're taking big breaths in, you don't need to just rely on the flow from the wall. You got a little extra oxygen in the bag. But if there's ventilated little valves, you have a partial rebreather because room air can mix and you can never get to 100% oxygen with little airs in your disc, or if you have punctures around your things. If you have a solid disc, then you are at 100% non-rebreather. So these will get you to 100%. You have to have the discs on the sides. If you are missing the discs, you will only be doing partial, even at high liters. Does that make sense? So you should be on a mask at this point. You're in respiratory failure. Where you go from there is if your patient is conscious and you need to suction them, this makes a great airway that, one, you've now got a clear airway. You can put in, these are very soft and spongy. I have a couple of them. Soft, spongy, they do not cause trauma when you put them in. You can use them on conscious or unconscious patients, but these will go in the nose and go to the back of the trachea. And you can do suctioning through there. It won't traumatize the nose as much. You can go straight to the back and clear out secretions. So this is a great adjunct if your patient is conscious and needs extra airway support. The nasopharyngeal airway or the nasal trumpet. Very nice, soft, spongy, easy to put in. You just put some lube on the end of it and stuff it in the nose and it goes right back to the back of the throat. And then that makes for easy suctioning of the patient and trying to get them an open, and keeps that open airway. If your back of your throat is collapsing or something, it will keep that throat open while the BiPAP and the CPAP try to work. Here is your BiPAP and CPAP, and I have a fun demo for you next week about PEEP. But until then, this is a video that can tide you over about its pig lungs. I actually have some lungs here that we're going to play with, but we'll show you what leaving a little pressure in the lungs will do. Okay, sorry, I had to change my volume. 1 second here. I just put myself into a loop. I am recording this for posterity. And then as far as the ventilator, so this is what I need you to know and not know on the ventilator. Let's see. This is all just nice to know, ventilator lingo. I'm not going to test you on this stuff. I'm not going to test you on what's on the screen here. This is not testable. Don't worry about that. This is all just for extra information. What I do need you to know is this slide, 100%. I need you to know what we are monitoring on the patient. Correct tube placement, cuff inflation. Make sure that you're suctioning them every 2 hours or more often if needed, and that you need to make sure that that we are not doing skin breakdown. communication, and then we are looking at our complications. So this is our expected. So you can just do care of the patient on the ventilator. What do we expect? I love the Grey's Anatomy thing. We all know why Garrick died. He wasn't intubated. But anyway, we do measure the depth of the ET tube and confirm it with an X-ray, and then we monitor and suction them and keep everything open. What we do not expect and how to prevent them. This is very important as well. I would want you to know the complications and the prevention of those complications and how to know if you have them. So we do not want ventilator-assisted pneumonia, no bueno, and these are our prevention keys for those. If the prevention doesn't work, how do you know that you have it? That would be probably what you're looking at. So this is what we expect to do to prevent it, and this is kind of what we don't expect. It didn't work. So we're saying we have a ventilator-associated pneumonia. We don't want that. We expect to prevent it. We don't really expect for you to have it. It's not a complication that we want. Expedation, we don't want them to take their tube out on their own without us planning to do it. Here are the things we do to prevent it, and here are the things to recognize that, oops, it happened anyway. And then we don't expect you to get a pneumothorax. You have a ventilator. It's supposed to be helping you, not hurting you. So here is what we're doing to prevent it, and here's what we do if you actually recognize it. You already know signs and symptoms of pneumothorax because we studied that. And then I would say yes, the common ventilator alarms and the common causes. There are 4 of them. High pressure limit, low pressure limit. There's 5 of them. Apnea, high tidal volume and low tidal volume. So yes, I would like you to know the common ventilator alarms, and we'll talk a little bit about more of these when we do our fun times next week. But I would like you to know these. The ventilator modes are not testable. They are for your information. So I'm going to just say, you don't have to worry about these, okay? I want you to know them if you're interested in them, but they are not testable, okay? So just to go through all of that, I would love for you to understand it. I'd love for you to look into it, feel comfortable. But again, if you're not going into intensive care, those are not your priorities. But I would like you to know the most common ventilator alarms and what they mean, because that is important in the care of the ventilator. So if you focus on ventilator patients, on the unexpected things, how to prevent them, and how to, recognize alarms and know our care of the ventilated patient, that's what I am focusing on respiratory failure. So respiratory failure has 2 flow charts. Conscious gets non-invasive ventilation, BiPAP, CPAP, and hopefully things get better there. Unconscious patients or patients that can't protect their airways are going to get intubated, ventilated, and I would like you to know how we monitor them, unexpected things that we're trying to prevent, and common ventilator alarms. So that was a super